So good evening, everyone. Welcome to our webinar on hernia treatment. My name's Louise and I'm your host for this evening. Our expert presenter is consultant surgeon, Mr Okaro. This presentation will be followed by a Q&A session. If you'd like to ask a question during or after the presentation, please do so by using the Q&A icon, which is at the bottom of your screen. This can be done with or without giving your name. But please note this session is being recorded, so if you do provide your name, that will be in the recording. If you'd like to book your consultation, we'll provide contact details at the end of this session. Paul from our private patients team will be available to take your call at the end of this session as well. I'll now hand over to Mr Okaro and you'll hear from me again shortly. Over to you, Mr Okaro.
Yes, thank you. Good evening, everyone, and thank you for joining us today to talk about something that is quite common. And hernias. So hernia obviously is a condition that really occurs when you have a protrusion, an abnormal protrusion from the abdominal area. And this obviously is something that is quite common and normally presents in the groin. So we'll move to the first slide. So a little bit about my background. I'm a consultant surgeon. I've been practicing for about nearly 20 years as a consultant, doing quite a lot of different surgeries with an interest in hernias and other things such as sort of GI work with sort of bariatric and weight loss. But today, as we said, we'll be focusing a lot on the hernias.
I think you just need to swap the slides yourself at the bottom of the screen on the left-hand side.
Oh, I'm gonna.
Of the arrow to the right. Perfect.
So what is hernia and what really do hernia symptoms represent? So the first thing, of course, is that hernias, as I mentioned, is where there's a protrusion. Now, the commonest hernia is an inguinal hernia. And we're really going to cover things like the causes, the symptoms, the diagnosis. This is obviously what the session will cover. Then really the key part will be treatment. And then, of course, the question and answer sessions will come after that. So when a part of the body protrudes from the cavity, in this case, the abdominal cavity, then that is what is described as a hernia. And the inguinal hernia is in the groin, and that is by far the commonest. And the inguinal hernia can be obviously on one side, or it can be on both sides. It can cause pain. Sometimes it may not cause pain, but it's usually quite noticeable for most patients because they start to feel a bulge and they start to feel discomfort. In the early stages, sometimes it's not clear, particularly for those that are quite athletic, and sometimes you do have to have an ultrasound to confirm it. But essentially, I think any patient that has a sort of an irritation in the groin, maybe also in the testicle, sometimes in males, is sometimes an indication that there may be a hernia forming. And hernias can unfortunately take even up to 6 months or more to become evident. Of course, if you ever have any concerns about maybe having a hernia or any lump in the groin, it is essential to talk to the doctor, see your GP, and as I said, possibly you may need to have an ultrasound. Now, for those patients who have established hernias, so these are patients who have hernias who may be waiting to have surgery or maybe have decided not to have surgery, then some of the risks can occur. And these are, on occasion, can be quite serious if the hernia gets obstructed, which means obviously whatever's inside the hernia may be a piece of bowel or also may get what we call incarcerated, and that does sometimes become an emergency. And it's fair to say that hernias coming as emergencies still occur, but by far the majority come sort of planned or elected into the clinic, and then of course we have conversations about treatment. Not surprisingly, hernias are caused when usually men commonly, and then of course can affect women, but it's usually from straining. If you do a lot of straining, if you're either doing manual work or if you do a lot of sports and exercise, you can get hernias from that. So really anything that makes the abdominal area or the pelvic area get under pressure, even coughing or sneezing can occasionally cause hernias. So anything that means you strain for quite some time can, force or predispose you to forming a hernia. And it is worth mentioning that men are more prone to hernias for the simple reason that their the testicle has come down a natural sort of trajectory, which is called the inguinal canal, and that's why men tend to have a slightly higher incidence of hernias than women. Now, for those patients that are suspecting they have a hernia, I mean, as I mentioned earlier, quite a large number will have no pain, but there are some that may find it sensitive to touch or indeed painful. Of course, the swelling is usually quite evident in most instances, but that's not always the case. In a patient that has a very small hernia, or a patient who, for example, is quite muscular, it is possible to have a hernia and actually not strictly easily feel it. And maybe the only reason why one's attention is drawn to that is maybe a sort of an ache, either in the groin itself or maybe possibly for a man in the testicle or the scrotum. But particularly the commonest story is patients who maybe they are exerting themselves either by walking or by doing some sort of sport, will notice a sort of a bulge or a swelling, and this would sort of classically kind of disappear when they lie down. It goes away, and whatever discomfort they may have will kind of disappear then. So that's usually the commonest presentation, really, is swelling after exertion, and it goes away upon maybe resting or lying down. So that's quite common. Now, the diagnosis is really pretty much centered on our initial discussion. If you have the symptoms as we sort of described, and you have the sort of swelling and it goes down, then I think the diagnosis is usually not in doubt. But of course, a physical examination by the doctor is essential, because there are other things that can mimic hernias or can sort of masquerade as hernias. And so it isn't, an automatic kind of decision that you have a hernia. So I think it is important to get examined. And even when you examine, there are times when something is not easily noticeable. Sometimes you can't feel a hernia, and that occurs, I'd say, in about sort of 10 to 15%. The patient comes, the story is very much like a hernia in terms of inguinal hernia, and you just can't feel it, even if the patient stands up and coughs. In that instance, an ultrasound is usually really helpful. And we're probably doing more and more ultrasounds for hernias now these days. Of course, the GP, if that was a GP that saw you, for example, they would usually refer you to come and see a consultant surgeon for an opinion. Treatment. Now, it's important to say that unless otherwise sort of suggested, all hernias largely need to be operated on. Of course, every case is kind of decided on the merits of each patient's conditions, but generally speaking, as a rule, a hernia needs to be fixed. And the reason simply for that is hernias don't get better on their own. They don't go away, and the chances are that they will become larger and maybe potentially more risky and dangerous to the patient. So it's always suggested that surgery should be the course of action. But I mentioned earlier, it is important to make the diagnosis of a hernia. I think that's quite important. So if there is doubt, of course, one may run more tests, but if it's a very clear case of hernia or inguinal particularly, which is the commonest hernia, then most times your doctor would be recommending surgery. Of course, if you have obviously medications and other drugs that may obviously be needed to maybe for pain relief and so on, that's absolutely right. But some patients like to wear on occasion a hernia belt, which you can obviously find is talked about in the literature, but most times surgery is what we do. And coming to surgery, I mean, it's important, of course, to kind of touch on that hernia surgery has, I mean, hernias have been repaired for centuries, so this is not a new operation. And in all fairness, the evolution of hernia surgery has come quite a long way, particularly or most significantly with using of materials or meshes, which are really simple devices that are used really to try and reduce the chance of hernias reoccurring. And that's really why the mesh or the gauze or the artificial material has come along, and it really has made a big difference. Now, how you place a mesh or where you place a mesh becomes then the primary consideration when it comes to hernia surgery. And that really puts hernia surgery into two broad categories. Open surgery, which means that the mesh will be placed normally on the surface of the muscular fascial part of the body, which in the case of the groin would be down obviously in the inguinal area. So again, open surgery is placing it onto the surface, so of the muscular fascial part of the lower abdominal wall, or it could be keyhole or laparoscopic, where the mesh is actually placed behind the sort of the structures, so it's put internally, so it's a much deeper placement of the mesh. And they're both very good techniques. I think very much is really what the patient prefers, or maybe what the surgeon prefers, but both have very, very good results generally, I think, because the meshes have evolved significantly. So, but in summary, we do like to maybe recommend keyhole for patients who have hernias on both sides. It stands to reason, if you've got a hernia on both sides, rather than having an open operation, one on the left, one on the right, is to maybe combine the operation with one incision, so one series of cuts in doing both sides. And that's obviously where laparoscopic probably then comes up as a bit of an advantage. The other reason why you may favor a laparoscopic or keyhole hernia operation would be for patients who, for example, have hernias that have recurred. So they've had an open operation in the past, and it needs to be fixed again for that reason. Doing it keyhole has an advantage, partly because it's new territory. So this is not where you had any scar tissue in the past. So there is no doubt there is an advantage doing it that way. And of course, the third reason to do it keyhole, if the surgeon's sort of given the choice, or the recommendation would be particularly for patients who maybe are very, very, very into the sports and they want to get back into the maybe into the sporting sort of environment quickly. You could argue that that may be an advantage. Having said that, most patients, if you see them at 6 to 8 weeks, all the studies very clearly define that they are pretty much all the same at about 6 to 8 weeks, really, in terms of pain control, in terms of integrity of the hernia repair, or any aches and pains, or also in the groin. So I'll just maybe go into maybe a tiny little bit more detail on the two different approaches to hernia surgery. As I said, the laparoscopic is a keyhole operation. It's been around, I would say, for at least 15 or so years. It's still not the commonest way to do the hernias, it must be said. I think up and down the world, it's fair to say that open hernia surgery, so where the mesh again is placed on the surface, is still by far the commonest choice. But laparoscopic or keyhole is coming along, I think, and gaining quite a lot of ground. Now, I personally do both. If you ask me which one do I prefer, it really does depend on the circumstances of the patients, really. But they're both very, very respectable operations when it comes to repairing the hernia. Now, it's important, I think, to just remind everyone that the purpose of the mesh, the purpose of the gauze, the mesh, the material that we put in is to create scarring. So scarring, which is fibrous tissue, which is the bonding or the reinforcement, is actually critical to hernia surgery. And the reason for that is because the tissues are already weak and you're looking to strengthen them. And in the old days, they used to do a lot of stitching, but these days, I think using meshes really does significantly compensate. But it is important to mention that the meshes really don't create their maximum scarring or the maximum reinforcement until about 12 weeks. So that's why it's important in the first 6-8 weeks to take things easy and not put too much pressure in that area. So again, a little bit more obviously on the keyhole. Of course, the purpose is to place it in a deeper position. You get to see things a little bit clearer in terms of the structures. There's obviously a little chance to put a slightly bigger mesh, but none of these, I think, have a significant advantage. The key is to place, as we can see here, is to place the mesh in a position that will create enough reinforcement over time that there will not be an emergence of any weakness kind of going forward, really. So in a much more functional or more practical sense, what do you kind of expect, really? The vast majority of hernias, both open and keyhole, are performed under general anesthetic, which means you will be given the full anesthetic. Surgery open can be anything from about 40 to 50 to 60 minutes. In primary repair, in recurrence, you can get up to an hour and a half to have the surgery done if it's on one side. If it's on both sides and it happens to be open for whatever reason, then of course we kind of double that time, really. If it's keyhole, average theatre time, normally about 45 minutes to an hour. Most people, of course, if it's day case, which is what we're doing mostly, we tend to try and get people home the same day. So you're looking at possibly going home after your admission and then obviously surgery and then recovery, possibly something like 6 to 8 hours, really, as a point of discharge. Of course, if you happen to have surgery late in the evening, we tend to keep you for the night, just so that you obviously, once you wake up and you obviously are comfortable, the following day you should be able to leave and obviously go out of the hospital. Things like simple painkillers, laxatives, because of course constipation is something we want to kind of avoid, really. And I think, yeah, that brings us to the end of my sort of presentation, really. And I think over to Terry, really. I think you've got a testimonial that you're going to present.
Yes, if you just press play at the bottom, towards the bottom of the screen, and you should see Terry.
Oh yeah, there it is.
Yeah.
Let's see if it works. Looks like it's working.
I was experiencing some pain and discomfort in the lower stomach area. I quickly had appointments to see, make sure that the diagnosis was correct, which he confirmed, and he set out the procedures, how it would roll out for me. The operation was carried out in August, having only received diagnosis in early summer, so that was marvellous. The nursing care was first class, and a little bit being like being in a hotel, being on holiday. Your every need was pampered to, and you're made very comfortable and at home. I think after about a month I was back playing golf and not feeling any ill effects. Yes, the highlight of my experience at Benenden Hospital was the seamlessly smooth transition from operating theatre to my private room, where I enjoyed a light snack in the knowledge that everything had gone fine and I had the rest of my life to look forward to, unhindered by having waiting list issues hanging over me.
Right, I think if we just click onto the next slide, we should just next. There we go. So now we're going to do a short Q&A session. As you're seeing on your screen, there is a 50% discount on your initial consultation from viewing this webinar. Yes, so we have some questions and we will go through those now. So first question, does Benenden offer surgery for hiatus hernia?
Yes, I think it is. I mean, as I mentioned earlier in my sort of resume, I mean, the two of us, the two upper gastrointestinal surgeons, myself and Mr. Ahmed Hamouda. We also the bariatric surgeon. So yes, we do a lot of hiatus hernia surgeries and fundoplication. So yes, we do, and it's usually laparoscopically. Yes.
Thank you.
Just go through. We've got another. You want me to go?
Yeah,
I can
no,
see them there.
Yeah, it's fine. I can read them out.
Okay.
What initial tests do you do, and is it at the GP or in a clinic at the hospital?
Well, I mean, the tests, I think, as we mentioned, of course, the GP always, if called upon, will be able to see the patient because, of course, that's what GPs are very happy to do. But we have patients who come directly, as you know, they feel they've got a hernia, they go online, they're looking for somebody or somewhere they can be seen fairly quickly. Yeah, we get on and see them. Of course, if it's very obvious, so patient's story adds up, you examine the patient, they've got a very obvious hernia either on one side or on both sides, then it's really a conversation about what's the preferred choice of surgery, provided the patient, of course, is in good health. So it really then becomes quite straightforward, really. If, on the other hand, the history or the story is very indicative of a hernia, and I kind of examine the patient and I'm kind of not entirely sure, then I get an ultrasound. And that can be done, pretty much within 24 hours, get a result, and then decisions carry on as before. So I would say about 70%, 80% of times, just the story, the examination makes it very clear and plans for action are made.
Great, thank you. Okay, this person says, I'm 42 and I do labor intensive job. How could I avoid getting a hernia?
Yeah, it makes sense really as a question, I think. Yes, how do I avoid getting a hernia? But in reality, I think it's always a hard response or a hard concrete answer. If you speak to the physiotherapist, they will talk about making sure that you get a good posture when you do your lifting. Of course, you have to, pick things up, maybe using your bending at your knees and your hips rather than putting the strain on and so on. So I think staying physically strong in terms of your core strength is probably good for just general lifestyle and wellness. But specifically for a hernia, I'm not aware of any prophylactic gym exercises, I think, for preventing hernia. So unfortunately, it is obviously sometimes an occupational hazard. So, but I think just wellness and be careful how you lift, I think, is always a key, advice.
Great, thank you. Just to mention, if you have your hand up, if you could just type the question in, that's the best way to do it within this webinar. Next question, could hernia symptoms mean something else more serious?
Yeah, I mean, I think the simple answer, of course, is there's always a possibility that, we are seeing when a patient comes with a symptom of a hernia. This is just an inroad into something else. But importantly, as I said, if a patient has pain, discomfort, swelling, the priority for the hospital, for the clinical team, is to make a diagnosis. That diagnosis has to be established with certainty. Now, if it does point us in another direction, of course, yes, that may occur, but not that commonly, I think. Now, the thing to mention that I think is relevant in maybe in relation to that question is that if you have a condition, let's say you have bad constipation, maybe because of IBS or something else, or you have a prostate issue for men and you're constantly straining to wee, or you have an issue with your chest, lots of smoking, then you could well be at higher risk of getting a hernia. So there's where that link is maybe more evident, really.
Okay. In terms of recovery, how long after surgery would this person be able to go on holiday, including a long-haul flight?
I think it's always sensible to wait about 3 to 4 weeks before you go on a long haul flight after any major surgery. So I would probably say about 3 to 4 weeks, I think.
Okay, thank you. This person says, can hernias develop on both sides of the body?
Oh yeah, I mean, yeah, left and right, absolutely. Absolutely, yes.
Cool. And this person says they have a sliding hernia and they're waiting on fund application with NHS. Is this something that they can get quicker through us?
Of course. As I mentioned, hiatus hernia, sliding hernia, they are sliding hiatus hernias, which is a fund application in essence. So absolutely, yes, absolutely. Something we can help them with.
Okay. We've had a few other, oh no, here we go. How long is the full patient journey?
Obviously, very tricky questions. full journey. The patient comes into hospital, to the clinic. How quickly do you get your chance of getting on an operating slot, and how quickly do you recover? I think on average, I would say for a patient who's really keen to have surgery really quickly, I'm sure within 6 to 8 weeks, you can get seen, listed, operated, recovered, and then back to the office. So I'd say about 6 weeks, but otherwise you're looking at about 2 to 3 months.
Yeah.
For a routine pathway, yeah.
Yeah. Okay. Thank you. That's most of our questions, and we are actually running out of time. So I think we will round up there. So yes, thank you very much for joining, everyone. Paul is on the line if you'd like to discuss or book your consultation. He's from our private patients team, and he's available this evening until 9 p.m. to take your calls. He can talk about any cost questions you have, or any other kind of more complicated questions that you have regarding the process, not the operation itself. We have the expert on the line for that. Also, our lines are open between 8 a.m. and 6 p.m. Monday to Friday. As I mentioned earlier, we are offering a discount for joining this session with the terms on the screen. At the end of this session, you'll receive a short survey, and we're really grateful if you could spare a few minutes to let us have your feedback. It helps shape future sessions. And our next webinar is on Monday, the 20th of February at 6 p.m. and it's on common eye conditions and treatment. So just visit our website to sign up to that. So yes, on behalf of our expert team at Benenden Hospital, I'd like to say thank you very much for joining us today, and we hope to hear from you soon. Thank you very much, and goodbye.
Thank you.
Thank you. Goodbye.
Bye-bye.